So next, I am delighted that I get to present Dr. Erin Bonar. Dr. Bonar is a licensed clinical psychologist and associate professor at the Addiction Center in the Department of Psychiatry at the University of Michigan. She's a content lead for her expertise related to cannabis and injury, as well as prevention of sexual violence at the U of M Injury Prevention Center. Dr. Bonar's research focuses on using novel technology-driven solutions to prevent negative outcomes associated with substance use among youth and adults. Please remember to use the Q&A, and you don't have to wait till the end to put your questions in. And please welcome me please join me in welcoming Dr. Bonar.
Hi, everyone, and thank you for allowing me to join you today. I'm Erin Bonar, and I'll be speaking about virtual interventions for preventing opioid use and misuse among adolescents and young adults. I have no financial disclosures to report, and I want to acknowledge that the funding received for this project came from the National Institutes of Health and the National Institute of Drug Abuse and the Healing Communities Heal Prevention Initiative, and was awarded to myself and my MPI, Dr. Maureen Moulton. And I would like to take a moment up front to acknowledge that a tremendous amount of work goes into this study, both from a team of collaborators and from our study staff. It wouldn't be possible to do this without them. In terms of injury prevention, there are over 800,000 people who have died in the past 20 years from a drug overdose. And provisional data from the CDC for the current past 12-month period suggests that about 96,000 people have died. And about 2/3 or more are related to opioids. Overdose death has risen in all age groups since the turn of the century. And although prevention is important for all, our team's focus is on youth and young adults. This is because earlier initiation of opioid use and misuse increases risk for later development of opioid use disorder and other consequences. In 2020, our team at the University of Michigan Injury Prevention Center, in partnership with the National Safety Council, published a scoping review where we identified that the field was lacking in efficacious prevention interventions focused on opioid misuse for youth in the current context of the opioid epidemic. In reviewing the literature, we also identified a number of risk factors for initiation and escalation of opioid misuse for young people. In addition to having a prior prescription, these include individual level factors such as other substance use, including cannabis use and binge drinking, and mental health factors such as depression and suicidality. Despite the lack of interventions, members of our team conducted seminal work that set the stage for new virtual interventions being tested in our HEAL prevention study. This includes an emergency department delivered overdose prevention intervention for adults who misused opioids, which was later translated into a dissemination toolkit called Optin through our work at the University of Michigan Injury Prevention Center. This also includes prior brief interventions for youth focused on alcohol and cannabis that had secondary effects on prescription drug misuse, and a messaging intervention that used an online portal to address suicide risk with college students. Our two behavioral interventions targeting opioid prevention are described in the protocol paper shown here. Both interventions, a brief health coaching session and a patient portal therapeutic messaging intervention, are delivered virtually. Our virtual prevention interventions are rooted in motivational interviewing using the why-how model of MI. In this approach, exploring why change and how to change are both essential to elicit and sustain behavior change and are accomplished through the use of MI skills and guided by MI spirit. Our virtual interventions are delivered to participants who are in the emergency department or who have recently had an ED visit. This is a setting where we can reach at-risk youth, particularly those who are not in schools, to initiate behavioral health interventions. This is supported by a large body of work from our team and others that have shown that ED-based behavioral health interventions can have an impact on substance use and related injury risk. In the spring of 2020, we conducted a pilot trial of our intervention with 40 16 to 30-year-olds from the U of M Emergency Department. Youth and young adults were eligible for the study if they reported past year opioid misuse or past year use of opioids, such as those prescribed, and at least one of the following risk factors for misuse: recent substance use, binge drinking, depression, suicidal ideation, or a past year suicide attempt. We screened and enrolled those at risk for opioid misuse, provided our virtual health coaching session, and portal-based messaging for 30 days. The health coach session is about 45 minutes and is highly tailored and personalized to the participant and delivered over video conferencing. Our health coaches engage the participant in a motivational interviewing-based conversation that involves exploring substance use and walking through a number of scenarios related to opioid consumption and addressing risk factors. Similar to our team's opt-in intervention, the coaches use clinical decision support screens to structure the session and maintain fidelity. Prior to COVID, we plan to deliver our virtual interventions from a telemedicine health hub via video chat to participants in the ED using iPads, which is a scalable model for deploying behavioral health care across a health system. During COVID, we had to pivot to delivering interventions from staff at home to patients at home who were enrolled after their ED visit, and later from staff at home to patients in the ED as in-person human subjects restrictions were eased. Our second intervention is a therapeutic messaging intervention delivered using software that mimics a patient portal and is modeled after a system used in Dr. Cheryl King's EBridge study. Here you can see a beta version with fake participant and therapist messages. Similar to what one would see in electronic health records, our coaches can see assessment scores used for tailoring the messages. We send at least 8 messages and respond to any participant replies over a 1-month period. And based on the assessment data and participants' responses, we address the topics shown here as relevant in addition to opioid safety and disposal. Again, this intervention is highly tailored and personalized to the individual participants' unique combinations of risk factors, strengths, and goals. In our spring 2020 pilot, these virtually delivered interventions were highly acceptable and found to be feasible. And we met MI-based fidelity benchmarks as well. Based on this work, we initiated our ongoing randomized controlled trial, which involves a fully cross-factorial design where each intervention strategy is examined alone and in combination, compared to an enhanced usual care control group, which includes provision of community resources. In addition, everyone in the trial receives an opioid disposal bag for safe disposal. We also recently received a supplement to increase representation and inclusion of Black and African American participants. As of last month, we had screened over 2,000 ED patients using in-person and remote methods. And to give you a sense of the opioid use and misuse in the population screened, we found that 69% of young people screened had no opioid use in the past year. Additionally, 7% reported opioid use, but did not exhibit misuse or any risk factors for misuse. However, 18.5% had opioid use and risk factors for misuse, and another 5.5% were misusing opioids. These latter 2 groups reflect those eligible for our RCT. We've enrolled over 300 people so far with a mean age around 24 years old. A little over 2/3 are female, and the majority are white. However, with our increased representation of Black and African American individuals, we're at 17%, and that will grow over time. And currently we represent 9% of the sample as Hispanic and Latinx ethnicity. Here you can see the current breakdown in terms of prevalence of risk factors among the sample. Cannabis and binge drinking are the most common substance-related risk factors, whereas a positive depression screening is also quite common at about 40%. Currently, our trial is ongoing, so I'm unable to share conclusive data with you. Our plan is to enroll nearly 1,300 individuals and examine behavioral outcomes over 1 year. So far, about 75 to 80 have been assigned to each condition, meaning we've delivered over 150 virtual health coach sessions, and we've had over 150 individuals receiving portal messaging. And we have activities planned around implementation and cost analyses in the later years of this project. In the absence of outcome data, I thought I'd share some of the participants' perspectives on these virtual interactions. From our pilot at follow-up, we asked participants to share some of the aspects they found engaging or useful in these interventions. This is not a formal qualitative data collection and analysis. However, I wanted to highlight some of their notable comments that you can see here. Participants found the resources we provided and the perspectives provided were helpful. They appreciated the social connection and non-judgmental, sincere, and respectful listening provided by our health coaches, and they had positive reviews for the video chat itself. With regard to the portal specifically, which can potentially cover a broad range of topics, We also asked participants to share which topics were of interest to them. And the response indeed does cover that broad range of topics, including mental health, opioid use, pain, overdose, other substance use and coping, as well as physical health and family issues. So I wanted to leave you with these perspectives on our virtual interventions, which we have found so far that young people to be quite engaged with and interested in receiving, and we hope to report outcomes in the future. And I'd like to thank you now for your time today, and also let you know that if you're interested in hearing more from this project, to check out our team members, Tiffany Wheeler and Linnea Bacon, at the concurrent abstract session today. And I'd like to thank everyone, and I'm happy to open it up now to any questions.
Thank you, Dr. Bonar, for that wonderful presentation. We have some questions for you that are coming in on the chat. The first one is, what are some of the technical challenges to delivering these virtual interventions?
That's a great question, because I think as we're attending a virtual conference, we've probably all experienced some of the challenges that our research team and our participants experience. So, low bandwidth, difficulty connecting, calls dropping, but beyond the technology, it's also the idea that when we're doing our therapy with people and we're in their real lives and we're doing our health coach sessions with them, that's taking place in their day-to-day lives. And so things happen, like their kid walks in, or their spouse walks in, or their dog starts barking, and the doorbell goes off or whatever. And so those things can be potentially disruptive or just distract from the therapy for a moment or two. It's very different than when you are maybe in a traditional therapy setting where you're in a pretty quiet space and most of the time no one just walks in. So I think that's one of the challenges, but I think that the benefit of being able to reach so many people in ways that we wouldn't have reached them before sort of outweighs those challenges.
It sounds like we're in sort of a new world where people are getting used to those sort of things. So, okay. And why, this next question is about the portal system. So why develop a portal system as opposed to just using the health system's existing portal system? Like, why did you decide to do that? Or what were the pros and cons that you considered?
Yeah, it's certainly something that we had to think a lot about and look into. And so there's a few key reasons why we chose to develop our own portal system versus using, our study takes place in the Michigan Medicine Health System. So Michigan Medicine, of course, has an electronic health portal. One of the first reasons why we did this was because currently, since this is a research therapy intervention, the messages that are being delivered in someone's portal, that's considered research. That's not quite considered healthcare yet. And so we wouldn't want some of those confidential messages to be stored in a patient's chart like any other sort of messaging that they might do through their health portal. So we really wanted to preserve confidentiality in research. This is something that very much could go into a health system's health patient portal because the features are the same. We're messaging, people are notified that they get a message, they can log in and they can respond to their health coach. Just like I message with my primary care's office or my other specialty offices. So the key reason really had to do with preserving privacy, although, and we wanted a system that really was only accessible to the researchers. At the same time, there's nothing specifically unique about that system. It could be deployed in any type of health system portal, regardless of which software company maintains a health systems portal.
It's really the content. It sounds like that's important. That could sort of go anywhere.
Exactly. Yeah.
Interesting. So here's a question that just came in. So the use of portals to deliver intervention content is really innovative. I'm curious, have they been used in other areas of injury prevention? And if so, how? And the second part of this question is, where do you see this applying in injury prevention in the future?
So one of the inspirations for this portal, and I mentioned it briefly in the talk, came from Dr. Cheryl King's suicide prevention study for college students. And that was a study that I worked on as a clinical supervisor, helping to therapists message with college students who were at increased risk for suicidality. And it used a very similar portal style and motivational interviewing style. So that in part really was an inspiration. There's some other research currently that's used patient portals to do psychoeducation around alcohol use and but not really use therapy. And I think that's one of the unique things about Dr. King's work and then our work is using it to not just remind people of appointments or provide an educational link or information, but to engage them in therapy and have meaningful conversations with them that might lead to behavior change. So in this case, it's about opioids, but it's also about other injuries due to substance use. And as I mentioned, suicidality is an inclusion criteria for our study. It is a risk factor for opioid misuse and later opioid use disorder. And so our interventions address that as well. So it's really cross-cutting in terms of various injury related risk factors and what it could be applied to.
So it sounds like that's sort of where this could go in the future then. So it's been used, for opioids and suicide and maybe other places. That's interesting.
I think it's a communication tool that for any type, and this is similar maybe to what Dr. Lynn was saying with telehealth, we can use this as a tool for any type of injury prevention that might involve behavior change and communicating with people about, things that might help them motivate towards safer behaviors.
Thank you. Okay, and let's see, there's another question I'm seeing coming in. How are your health coaches trained to deliver these interventions?
Yeah, so our health coaches, we have a variety of health coaches at bachelor's and master's levels. And I think, one of the things that I'm really proud of is that we've been able to train everyone and meet fidelity to motivational interviewing in our pilot work. And our training involves a lot of traditional motivational interviewing training. And I'm a member of the Motivational Interviewing Network of Trainers. I've been trained in how to train other people in that. So it's a pretty common series of types of, didactic and practice. But specifically with our role plays and our health coach sessions, one of the things that we have people do is role play our portal as well. And so we really give a lot of feedback and a lot of supervision to make sure that people feel comfortable and ready and meet our fidelity to MI. And I want to say one of the great things about, I think, both interventions, our portal and our health coach sessions and being able to train people is that the portal is written. And that is such an advantage over, for me as a therapist, who has used to doing live therapy, there's an advantage because you can edit what you're saying and really be thoughtful and make sure that you're, consistent with the theoretical model, consistent with what the intervention should be, addressing. Whereas in therapy, if you're sitting with a person and you're on the spot, sometimes you don't say things in the best way. And so the ability to edit is really great about our portal. And so that training and practice, I think, also gets people more comfortable. And then with our health coach sessions, there's a structured intervention guide, which again, can keep people on track. And I think both of these things are important, not just for our research training, but for having people be able to learn this intervention when it's implemented in the future. And that with some of our materials that we are developing through the research, we'll also be able to disseminate this and create, training videos and a full toolkit to eventually with these resources.
Well, that's great that you're thinking about like training and implementation later already, and that's wonderful. And I think this is a great example of how the center can generate sort of future innovative solutions within injury prevention. I know that this study was sort of the outgrowth of a prior work of the center, the Optin Study. That I know you were one of the PIs of that study with Amy Bonar. How did that study lead to this study?
I think that's a great example of how I think our work at the center and our work at the team spans populations and spans severity. So the Opt-in study really started with some work led by Amy Bonar and some others that that I was a part of that was a motivational interviewing structured session, similar in style to what I've told you about our health coach sessions, but addressing overdose prevention and overdose risk behaviors among people who were maybe further down on the severity spectrum. They'd had overdose before, they were adults, they're had a higher level of opioid misuse, and they were emergency department patients. And so that we learned in that study that this intervention was very, was effective at reducing overdose risk and overdose opioid misuse. That led to the Optin study, where we packaged that intervention into a toolkit that's online and available, and would be a resource, I think, on our Injury Prevention Center website that shows how to deliver the intervention with lots of training videos, with training tools, with manuals. That's something that's available to be disseminated, available for use. And that intervention, we were able to train community providers at 2 different social services agencies in the area. And so have the intervention delivered and paired with naloxone at these different sites to be able to address overdose risk. And so that really led us to think about that structure and some of the pieces of that intervention, but adapt it for this younger, more at-risk population in this study that I've talked about today.
Wonderful. It's nice to see that work on opioid misuse and overdose prevention work kind of expanding through the center. That's fabulous. Well, thank you again, Dr. Bonar. I really appreciated your talk.
Thanks.